Is that all?
Yeah.
I put in 7.
Did you?
But he did it in
Yeah.
one patient. He did it in one patient.
Well, yeah, mine was in 3, but it's okay.
Hey,
Yeah, I did 3.
Here we go.
and we're live in 5,
4,
3,
2.
1.
Welcome, everybody. I'd like to welcome you to the 2023 Spine Arthroplasty Triumphs and Defeats discussion case series. And we're going to change it up a little bit this year. And instead of just having straight cases, we're going to have topic discussions. And we have an exciting year planned. Today, we are lucky to have Dr. Todd Lanman, who needs no introduction, who fought the traffic of LA amazingly, and he made it here on time. But Todd is well known to all of us, and he's going to give us a discussion about maintaining motion or converting fusions and pseudoarthroses in both the neck and the low back into motion. So I'm sure this will be controversial. We'll have lots of great questions. We have a great panel as usual. And Todd, we appreciate you doing this, and we know you're a pioneer, so pioneers sometimes have to take the arrows, and so we look forward to a great discussion, and you can take it away. And we're lucky enough actually to have Dr. Marnet, who flew from France to Philadelphia just to hear this. So Terry, thank you for coming, and we have our usual Dr. Ziegler, Dr. Blumenthal, and several of our fellows on as well. And we'd like to thank all of our sponsors and also for SSF, Corey and Alexis for helping us get this on the road. Thank you. Okay, Todd.
All right. Thank you very much.
Yep.
So I'm going to talk a little about restorative motion surgery, I call it. And in the cervical spine, primarily, we'll discuss that and go through a little bit of technique. And I'm also going to show a few cases of lumbar restorative motion cases. So I'd like to start by figuring
Sharing
out
your screen? No.
Is it sharing?
Yeah, it's sharing.
Oh, okay. And I'm trying to figure out how to advance the slide. Where is it?
Todd, do you see your
Try the
PowerPoint in the lower right?
Or you could try the space bar. Sometimes that'll advance it for you.
Just moving the thing up and down. I'm so sorry. It just moves the bar up and down. It's so odd.
How about your arrow buttons?
I try right and left. It just is beeping at me.
Well, can you?
Oh, there.
There you go.
Okay, great.
Whatever I just did. So cervical sagittal alignment, and we're all familiar with lumbar sagittal alignment and sagittal kyphosis. We know that cervical sagittal kyphosis correlates directly with neck pain, and methods of measurement of cervical kyphosis, cervical lordosis, do correlate with outcomes. Certainly the cervical Cobb angle measurements are the most common measurement used for cervical lordosis. And this does correlate directly with health related quality of life outcomes. So the sagittal vertical axis, or SVA, also correlates with QOL, as well as larger C2 SVA correlations. So T1 slope angle, similar to sacral slope angle and thoracic inlet angles, also affect cervical lordosis directly, and the methods of measurement are varied. So the most common on the left is the Cobb method. Some use the Jackson and the Harrison methods. And then SVA is traditionally calculated, as you see on the right, from the superior posterior margin of C7 to C2. So I'm going to just lay some of this out there for the residents and fellows who may be watching. And these are different types of methods of measurement. Typically, we use the red C2 to C7 CSVA, and on the right, you see the angle of the T1 slope angle and its correlation with the sacrum, typically, and the lordotic curvature that correlates with a higher angle with a greater lordosis than a lower slope angle. So these correlations have been shown in multiple areas of literature. In fact, Jack has published this as well years ago, and he may not recall that paper. But operative procedures and anterior cervical spinal fusion certainly relate to this. And we've learned this even with single level cervical fusions do correlate by putting in the proper curve. And I think this is one of the great maybe miscalculations or challenges that the surgeon has when he's doing fusions, is really setting that sagittal balance appropriately of the cervical spine. And an abnormal cervical curvature predicts less postoperative improvement. So we know that conversions of anterior cervical fusions, and I did do a publication with my partner Jason in International Journal of Spine Surgery a couple of years ago, and we had a limited series. The series is much greater now, but we demonstrated neck disability index improvements in reversing some fusions, and we're going to show some of these cases, and I'm going to show one technique case, and we showed the VAS improvement as well, and these are all statistically significant. So by taking down fusions or pseudarthroses and reconstructing and resetting the normal motion of the spine seems to have been very useful. And the first time this happened was a patient of mine, was a woman from Texas, and she came out to see me. She had a 3-level cervical fusion. This is not her case here. And she had a bad disc at C6-7, and she was fused at 3, 4, 4, 5, and 5, 6. And I said, well, we'll put an artificial disc and bottom off with the artificial disc. And so she was happy about that. And she asked me, gee, do you think that it might be possible to reverse one of these fusions? Because I like to golf and I just can't get my head down, and my neck aches most of the time anyway. And I said, well, I looked at her CAT scan and her facet joints were all open at her old fusion levels. And so I said, well, the one right above it at C5-6 is open. I can try to release that. And if your facet joints move, well, I'll place an artificial disc there. And sure enough, as soon as I cut through, it was as if facets were just sitting dormant. She immediately started moving at C5-6, and I put the spreader in, and I'll demonstrate that. And it's like the facets are just waiting to be remobilized. And so now she has 2 discs fused out of 5 instead of 3 out of 5, which I think that's sort of the break or make for me. I think that when you have 3 out of 5 discs moving in most patients, they have a pretty happy outcome. So this is a technique example case I thought we could show. And I think I showed this at ISAS, and Jason presented this technique a little bit at NAS. I was out of country at the time. But this was a 47-year-old woman. She was from Chicago, and she came to see me with chronic severe neck pain. She had had a cervical fusion at cervical 5, 6, 6, 7 eventually, and that was in 2012. So this was 10 years ago. And C4, 5, she subsequently had a fusion in 2016. And she always felt as though her head was falling forward, and she could never get her neck in a comfortable position. She could not extend back. Her pain scores were rather high, and her neck muscles were wasting posteriorly. She had posterior foraminotomies as well. And one of the things that happens when you have people that are fused so long is what's really happening into the internal paracervical musculature and the facet joints. And here you see a cast being removed 8 weeks after, and you see the amount of muscle wasting and atrophy. And so after 10 years of posterior cervical fusion, you can also see that there's muscle wasting and retraction, and actually some paracervical banding of the fascia in her. And I believe that this does factor into their outcomes. So when we do these reversals of fusions, the outcomes aren't as rapid on the superior outcomes as you would expect when you do a regular arthroplasty, because these muscles and ligaments need to be remobilized and rebuilt and reconstructed as the patients heal. And so I always tell them, hey, normally artificial disc replacement surgery, patients are up and running in no time, but your recovery will take probably 3 to 6 months to where you feel much better. So here, and I'm illustrating this again to show the importance of the facet joints. The real key to these surgeries is the thin cut CT scan. And you see the sagittal, and notice that the facets on the right and left are fused at C5-6, but they are quite open at C4-5 and below. And she's got a degenerative disc above as well. So when we do these surgeries, we just do a localization and go ahead and get our AP lateral, and then mark midline after you do the plate removal. So I started up there, and here she's got bone graft for inner body. And I'll start with the drill and come down along the actual graft. And I tried to say, because if you look carefully at that fluoroscopic image, you can even see the residual old cortical end plate. And you try to keep that intact, because the worry is, well, gee, you're drilling all this bone away. Are they going to subside and so forth? So it is important to use a disc that can provide excellent end plate coverage. I find that when I use a disc that is wide, 19 millimeter wide, and 16 or 18 deep to get really good coverage, I have not seen a case of subsidence yet in any of these series. And then I'll drill right through the graft. So there's a lot of fluoro going on here, because you want to stay in the plane of the grafts as you work your way backward towards the posterior margin. And then eventually you'll get to the back, as you see on the left, and then you'll want to drill and do some planing, as you see on the top right. And then you've made a nice parallel cut. And when you do that, you'll see the space will open up, and you'll be able to put the spreaders in. And I like to work the facets a little while and remobilize them and sort of increase that ligament laxity. And then I did a trial. This is obviously a ProDisc C. Again, you see the wide end plate coverage from uncinate to uncinate and front to back. And so I really like to get that broad coverage to prevent subsidence, and then insert the implant. And then we moved on then to do the one above, as well as then go skipping C5-6 and then going below to the bottom and remobilizing that segment. So there you see the bone cuts, and you'll notice that the uncinate joints are really resected widely. That is not always necessary. Oftentimes, because most of these inner body grafts, if you look at C5-6, the one with the residual bone graft, it's a bit narrow, and oftentimes the sides are still open, and there's still disc material on the lateral sides. So right when you drill centrally and just being careful to stay in your plane, you'll break through. And as soon as you break through, you'll see that segment open up and mobilize. So then here we trialed and went ahead. You see, I use a larger implant on the bottom. And I like to do at C6-7, I like to have the center of rotation a bit slightly forward. This enables the patient to extend in this day and age of, tablets and phones, and the average person is on their phone at least 4 hours a day. There's a lot of flexion. So if you can have the center of rotation in the lower segment slightly more anterior, I find that to be helpful in allowing the patient to sort of restore some sagittal curve. So this is a little video of me after I make the cut, and I'm going to show you, I put the spreader in, and you can see the screw holes where the fusion was, but that's what happens. And then I like to mobilize for a while and play with those facet joints and really open that up. and just get that inner body space moving. But you see it you know, I remember when I was went to Germany a long time ago and watched some of these arthroplasties, they were like, oh, you never use the drill and you never want to cut end plate. Well, I think that's about all I do is use the drill and trim end plates. I try to leave the cortical margin of the end plate, but I do plane a bit and dust it. And yet not really having any issues relative to subsidence. So this is her final post-op film with neutral. Now, this is a recent post-op film, so it doesn't do justice. This is only 9 days, so she doesn't have quite the flexibility. And I did this surgery, I think, a year and a half or two, and I just talked to her about 2 weeks ago, and she's back in Chicago, and she's doing much, much better. She has a lot more mobility. I don't have her recent films yet to show you, but she's able to bend her head back and forth. And her, no, what's not advancing? Why? There we go. Okay. So we're going to look at some things, but cervical segmental motion at each one is important, as you would understand or expect from the fusion to the TDR when we looked at the averages of the levels that were reversed. And you can see a range of motion to 8 degrees. This is similar to what we see in the standard cases of this. Now, this is our N of 31 at the time. Our N is much higher now. And I haven't had time to dial down and get us more numbers, but we need more numbers in order to have a fair statistical analysis. But either way, when we looked at the pre-op NDIs, the pre-op VASs, and I just included only the patients that we had up to at least 1 year, and we had some up to 5. We see that there's statistically significant improvement in the neck disability index and the visual analogs at all time points measured, which is interesting. And we're very happy with that. We also looked at the SVA and T1 slope, and you think that the SVA would be statistically significantly better at the sagittal vertical axis, but it really wasn't statistically significantly better, but it is a bit better. And I think maybe with greater numbers, we might see that SVA improvement may become statistically significant. What's interesting, and the T1 slope angle, obviously you wouldn't expect much difference with that restoration of motion. There was a statistical improvement in the cervical lordosis overall in the Cobb measurements on the lateral neutral and the lateral extension X-ray. And I think, and I'm not, this is my personal hypothesis at this time, I think that even though they don't get a clear SVA statistically significant improvement, which one might intuitively think, I believe that as they restore motion, and if you just really watch people in general, when they're moving their head, they're often looking and they'll extend, people will stretch. And, these people are, especially multi-levels, are unable to move at all. So I think that being able to restore some extension is so important in their comfort level. And I don't know why, but that's sort of an intuitive feeling I have. So of the results in this, we had about 31 patients. We did restorative motion surgery that were over 1 year. No patients had subsidence translation or implant migration, and none of them had failed osseointegration or periprosthetic bone loss or infection. The range varied from 1 to 6 years from the date of surgery. The recent, we have several more recent cases left out than even then. It was 12 at that time, and it's certainly greater from this collection of data. We still need, like I said, we still need a greater number of cases to really have an accurate outcome measurement. And I want to do that carefully. The other critique of our data collection is some cases were pure restorative motion surgery where the patient had solid fusion and then they were converted to arthroplasty. Some were like a hybrid, if you will, where we would cut out a fusion and then do another level, as the case I illustrated, adjacent normal level. So that subset may be different than the first. And lastly, the non-unions. Those cases are phenomenal. I'll show you a case, how well they do. When you do an ACDF or you see a patient who's had an ACDF and has a non-union, and when you go in and remove that plate or that inner body and restore motion there and place an arthroplasty, their outcomes are just really quite significantly better. So I thought here, I'm about 20 minutes in, and I thought I would do the 4 cases, Rick. And
can we interrupt you for a couple of questions from the chat?
Oh, yeah, please. Yeah.
Okay.
Somebody
Todd,
want to know, do you always use a semi-constrained implant, or have you done them with less constrained devices? And what's your decision-making for that?
I've really mostly used a Pro Disc and Prestige LP. The reason I predominantly use those two is footprint size. They're both offer 19 millimeter wide and 16 and 18 deep. But the other thing that's really important is the Prestige LP. I always have around on backup because it offers a 7 millimeter tall, and Pro Disc only goes to 6. And so sometimes if I'm really cutting a fair amount of bone away, I need a 7 tall. And if I'm taking out a big graft, I was going to put this case on to show you, because this guy had really tall grafts that I did from New York, a 4-level multi-level reversal, and he had tall grafts. So I had to do some Prestige LPs because he needed 7 millimeters there. So I usually predominantly use those implants. I haven't used M6 or Secure C or Simplify here at this time, just because of end plate size and coverage predominantly.
So it's coverage and
Jack,
height.
you threw out the definition of semi-constrained or constrained or unconstrained. I don't know that there's a real definition of. I don't think you can say which implant. I mean, you can maybe say unconstrained, yeah, but when you say that, I don't know that the panelists or the people who are on this Zoom really know what you mean.
Well, it's talking more about the disc mobility, Scott. So we know certain implant designs have more potential for hypermobility versus.
Well, there's okay, like what? Like what?
Like a Mobi C in a
but
young,
what other one?
Patient with a long, thin neck.
Right, but what other one? I don't know that you can say that a Prestige versus a Pro Disc versus a Simplify has any. I mean, I don't know that you can put them into a box of semi-constrained, constrained, whatever. Yes, we all agree that the Mobi is a bit less constrained, but
yes,
I think the definition is just not that clear.
Yeah, Mobi would not be my choice for these types of cases. I don't think, just because of that. The core movement, as I've critiqued that, as you all probably know by now. But when you extend your head, the core moves forward, which is not the natural motion. So I haven't really used Mobi C in these restorative motion cases. I do use it occasionally, but I select carefully for that particular device. It is a bit hypermobile.
Rick, you're muted. You're trying to talk. Rick, unmute.
Todd, there's some other questions from the chat room. One was a pretty basic one. Do you get insurance to pay for these reversals? I suspect not.
Well, no. Sometimes I could talk privately to anybody about how to.
Okay, but in other words, insurance won't pay for it.
Insurance, if you tell them you're reversing a fusion, they'll be like, well, that's off label. We don't approve it.
Now,
All right.
having said that,
they always do.
having said that, treatment of acute arthrosis with an arthroplasty, we have got by insurance.
Yeah, I have had revision arthroplasty where I've removed one and put another one in approved.
No. A acute arthrosis of a fusion, I've gotten approved for an arthroplasty, but not a solid fusion. So here's my other question, Todd.
Yes.
Have you had patients that basically just said, I don't want a fusion. I'm not hurting, but I want motion. But it's not because of pain that you're revising them. And how are their results and how are they different from ones that are being revised for pain or acute arthrosis?
No, all of them have pain. And I'll show a couple cases here. Every patient that I've seen that has some level of discomfort or pain. I think that if they're not hurting, they're not Googling around trying to figure out how to get their fusion out of there.
All right, Todd, I have another question, and a couple panelists asked this, and I want to know myself. So when you are taking down the bone, are you using a barrel burr? And when you have to take down the oncovertebral joints, what are you using to protect the vert? Are you using a Penfield? Where you're putting it? What kind of drill and how do you protect the vert?
So I use the Midas Rex. I use the AM8. It's that 2 millimeter round burr. I use that to make my cuts. And then I used to go to a diamond when I would go out and take off the uncinnates by the verts.
Okay.
And I didn't stop doing that. I used to kind of protect with the Penfield outside. But honestly, there is a ligamentous layer, typically a thin layer. And as you dust out along those uncinnates, it'll melt away, and if you palpate it, you'll feel the soft membrane before you're looking at the vert. Now, I've skeletonized the verts before. I've never had a vert injury, knock on wood, but sometimes you need to do that to mobilize or to remove residual osteophytes, because some of these cases have, when we have a fusion, you get away with leaving foraminal osteophytes often because you've immobilized the segment and the bone spur no longer impinges. But if I'm remobilizing, that spur is going to engage that nerve root and cause pain. And so in those, I really go out and do remove the uncinnates. But now I'm just using the standard AM8 all the way across both sides.
Okay, so just you're hoping on that thin layer between you and the vert, huh?
Yeah. Well, yeah.
And let me ask you, do you ever just make it thin enough and crack it, like you showed how you're testing or trying to mobilize that disc space? Does it ever get thin enough that you can just crack it?
Yes, absolutely. That's right, Rick. Yeah.
All right. Now follow up to this.
And put that spreader in, and you'll hear it'll pop, and it'll open.
And Todd, you made a really good point that everybody should, take heed of, is that the thin cut CT to look at those facet joints. But it is kind of amazing how sometimes the facet joints fuse and they don't fuse. Any idea?
I know it's odd. It's odd. And sometimes you remember the CT, the thin cuts are important because the CT is an average. So it'll take, if you do a standard 3 millimeter, it looks like they're fused and they may not be. So it's important to try to dial down to 1.5 millimeter.
All right. And Todd, one last question from me, and then I'll let anybody else ask a question. How long does it take you? So you made your skin incision, you're now starting to drill. How long from start to finish putting the disc in at each level does it take you?
I'd say, for each level.
Don't exaggerate. We know surgeons always under exaggerate. So don't exaggerate.
No, I'd say 1.5 hours. I mean, because normally I can do a disc at one level of standard in 45 minutes to 1 hour. I'd say it takes an extra 30 minutes because there's more prep. And if I'm releasing, I'll go to the back, and you'll know right away. Sometimes they have never taken down the PLL back there, or sometimes they have. If they have, I use the microsec angled curette. I have to do a little release along the dura. I haven't had a dural tear yet, knock on wood, but then I'll go out and trace the roots out. And usually the roots are what everybody's left behind, because a lot of these patients still have arm pain and a trapped root.
Okay. Any other questions?
I think Todd's
All
got
right,
some
well-
cases.
Yeah, let's go into do your cases, Todd.
Okay, so I'm going to show two cervical cases that I encountered. This one, this is a 60-year-old woman. She came from Louisiana, chronic neck pain, and she had undergone 4 cervical fusions. The last one was in April of 19, and she had a pain score of 8 to 9 out of 10 in her neck constantly. Neck pain predominantly. She did have some left shoulder and left arm pain at 5 to 6 out of 10, but her neck pain was 8 to 9 out of 10. And she also complained of lack of range of motion. And her doctor there had recommended that they extend her fusion down to thoracic 2 with pedicle screws. And she came to see me, and that's her x-ray there, but we're going to look a little deeper into that. So again, I get the CT scan, and at C6-7, she's got the non-union. And you see the crack through the graft on the bottom left. And then you see that the bone isn't fully healed around her peak interbody graft as well. And this level's clearly a non-union. Now, I then do what I usually do, look at the facet joints and make sure they're all open. So all her facets were open here, and she really wanted to get her neck mobility function back. She had been miserable ever since the multi-level fusion. And so I went ahead and reversed. These are both extension films because I was here, I'm showing you the Cobb angle difference of her cervical lordosis. This film I took on the right is 4 days post-op, and she came in and said her pain was 0 and her arm and neck were gone. And she remobilized, but if you notice, her extension goes up to almost 36 degrees from almost just below 19, and she's able to really gain much more lordotic posture. So this was a big win. Obviously, I can't reverse the upper segments, but we reversed these. So now she's got 2 out of 5 fused. So she has really excellent range and was very happy with the outcome. Not always a pretty picture on that extension where you see some implant impingement posteriorly, but nonetheless, she did extremely well. Does anybody have questions about that case? Because I'm going to move to case 2 just to show you a solid fusion. So this is a case of a kind of a reversal of 2 solid fusions and then repair of a non-union. And then the next case is a 3-level fusion.
Todd, before you go to that, I want to ask you a
Yes.
question. So you've shown us the extension, and yes, it doesn't look pretty. What about her flexion? I mean, did she have significant, obviously more motion you had before, but how did that look?
Yeah, she, I should have these up. Yeah, she moves well in flexion, and she's got good mobility there. And again, those films were 4 days post-op. I have another set that is more recent, that it was about a year post-op now. And she's got good mobility on flexion and extension. I've learned to do better bone planing to get a more parallel cut for the implants so that they sit prettier and they function, I think, a little better. But she doesn't have pain related to the the misangulation of the implant there in extension. The bottom one looks the best, which I used, and that's an XLD, an extra large deep on the bottom, and then the other 2 are just the 16mm deeps.
And on the very top one, it looks like the inferior end plate has subsided into the vertebral body, or is that the way you planed it down, Todd?
No, I think I planed it that way. That's critique of my own cutting. I should have planed that vertebrae more.
So
correct.
obviously
It did not subside.
Okay, Todd. So you're really skilled at, making sure the end plates are as parallel as possible. Any tips for us? Because, I'm a little loath to use the burr inside the disc space because sometimes it chatters, and I know the high-speed drills don't chatter, but sometimes they do. I mean, what are the tips to make sure you make nice parallel end plates if you're going to attempt something like this?
So sometimes I will measure from, if I'm not clear on the fluoro or the images that I'm making parallel, I will measure from the disc space above and measure down on each side to make sure that I'm equidistant based on my AP fluoro as well as my internal view under the microscope. And I'll measure, and then as I cut gaps, I'll measure again and make sure that I'm making parallel gaps parallel to the disc space above. And then when I look in through the scope with the retractors basically out with some gentle traction, I like to use, I do not use the internal Cloward spreader there. I tend to just use head halter traction, and I have anesthesia or the rep just pull to open that disc space. I think it opens more naturally that way without the potential of changing angles, because if your the Cloward distractor pins or I'm sorry, the where you put the pins in the bone, if they're not perfect, you can tilt your vertebrae and get misangulation. So I like the anesthesia or the rep to just pull directly parallel to the floor. I tell them to go water ski, and I said pull, and I watch that disc space open. As long as I'm watching that under the microscope and I see that the cuts look very parallel from front to back, I'm pretty confident I'm going to get a well-seated disc. So that's one of the tips I do. And if it looks like it's like this when I'm looking down and it looks like a wedge, then I'll plane more until I see it look more parallel, because I don't want it to impinge like it does here at our C45 in the posterior margin.
Can I ask Dr. Terry Marnay? Terry, is the most senior experienced cervical arthroplasty surgeon on the website tonight? Are you concerned about the posterior impingement, and have you seen any edge wear or any failures when that happens?
Two things. The first is, if you look to the pre-op, there is some extension and angulation between the plate above and below. Even it's difficult to see with the superior screws. And immediately when you release that, the spine is going in extension. So I don't know what can be the prevention of that, and probably to bear a little bit more posterior, because you have probably an edge backwards that has made your inferior plate or your superior implant in this inclined position. It's ugly, but with 20 years of experience, that it does. I have reviewed all my cases and recently, and I have some of them like that, as they have never made any I would say device or material problems. I would like to ask Todd, next time, I know it's very difficult to measure my obsession, which is the rotation in cervical spine, as you know. Yes. But for that type of case, because you have to demonstrate the validity of your concept, just take photographs of the patients turning the head before, or a short video, and turning the head after. Here you will see you gain 30 degrees in the rotation right and 30 degrees in rotation left. I'm sure of it.
Yes.
And probably
good idea.
The most and you know what is very important, and I think you have heard that before from my part. All the cervical motion is combined with rotation and inclination, because as there is a lordosis, there is no rotation without all of the discs are not working in the same axis. Everyone has his own axis in rotation, so they need inclination too. And what is interesting here is that if you take picture of them, you will see how wonderful is the rotation of your patient, and how is that changed completely the behavior of the dynamic of the spine. So last question I have, and it's not a bad question, is an interrogation.
Okay, I'm ready.
For everyone, I'm wondering, because I have experimented that type of thing. They have arm pain before. You don't decompress anything. You were not seeing any compression. And they have no more arm pain after that. How we can explain that? Okay, the neck pain I can understand, but the arm pain, where was it coming from? I have no answer.
In this patient, it was coming from the non-union at C6-7. I believe she was engaging her root on that left side from the non-union at the C6-7 level.
When you have a large fusion, at the level of the incus, typically you have a plan to go because it's not fused there. And the only few cases I have made like that, following your, I am not the pioneer here. I have just followed what you have done. Is that what was interesting is that it's not fused on the side, and we have a good plan on the incus. With the resection of the incus, we can find the plan of the canal before to take off all the. So the risk to go too deep and to be in the canal when we remove the graft is cancelled if we go laterally and cut the incus, because at that moment is good. But if we cut the incus, I can tell you, if you cut the incus on both sides, put a keel, because if not, the inclination can be very, very unstable.
It's interesting you say that, but I studied that, Jason, my partner and I, and we did 1, 2, and 3 level cervical prodiscs in cadaver models, and we measured, and we did total uncinate resections and found no mechanical instability related to that. Everybody thinks the uncinates provide so much stability, and I would say, at least with ProDisc, we did not find that on our cadaveric studies done. We're trying to publish that, but
anyway. It's interesting.
Yeah. So
you debunk some preconceived ideas.
Yeah, I do not believe I am certain the uncinates are not relevant here in stability with this, with the fixed core device, for sure.
Yes, I'm sure.
Scott?
All right, 2 questions. One is from Mohammed Maj, who asked a really great question, which is, if pseudarthrosis is painful because of a little bit of motion, how does restoring motion help the pain from a pseudarthrosis? And I'm going to ask question number 2. A solid fusion, why is that painful, and why does restoring motion help the pain? And that's kind of a correlate to the question I asked before, is what if patients come to you and say, I just don't want a fusion, I want motion, I'm not hurting? So go for it.
Well, to answer yours first, I believe that most of these patients, like you see here on her left, she cannot get an extension. And so even though the surgeon did a reasonably nice appearing film, I think the lordosis angulations are underestimated on what they need to be with a proper fusion. And I think that these people are slightly flat. And I believe that is a general neck pain contributor all the time, similar to flat back syndrome lumbar, where they get pain up to the thoracic, and all, because your body's always trying to re-extend to getting that mid C2 back somewhat. And you see here her extension, where her pain really went down. She's able to engage, significantly more, 16 more degrees in extension. And I think that's, I think, as I said, my hypothesis is that's really the neck pain generator. Now, non-unions are.
So let's just agree, and let's see if any of the fusion people on this call or on this Zoom disagree that for axial spinal pain, fusion is bad and motion is good.
In general.
Well,
I mean,
you
we all
know
have
what?
fusion patients that do beautifully and don't have any pain whatsoever. So I do not want to imply that every patient has multi-level fusion. I have a young lady with a 3-level fusion. She had horrible neck pain. I did her fusions over the years ago. She has terrible pain. And I said, you know what? You need a little more angulation. I cut 1 level, refused her, and added 10 more degrees of lordosis, and her pain went to 0. And I talked to her routinely. She wanted to go to dinner last Friday. She lives in Colorado.
Very nice.
You know, so cervical fusions work, but I think oftentimes when I'm seeing these particular patients, you see they're a little flat and they're not quite, the film looks pretty, but they just probably for them and their mechanical angulations are not in enough lordosis to relieve the neck musculature, which is then in a constant pull and gives them that achy neck.
So think of that theoretically. So theoretically, there are deformity surgeons that do fusions for axial pain and deformity. They try to line them up as perfectly as possible. And if you don't get it perfect and their muscles are at disadvantage, we can do better by doing a dynamic implant. That's what I'm hearing. I'm not necessarily.
You would be correct, because your brain will put your head or your spine where it naturally wants to put it. And if that's restricted, the more that's restricted, the more pain they're going to have. If they're not.
So by that same token, we have a better chance. We have a better chance of as motion preservation surgeons of helping axial pain by preserving motion than by doing a fusion that's just a few degrees off that could cause a mechanical disadvantage for their.
You are 100% correct.
And just to reinforce that, Scott, you remember Matt Gwinnett had published the 10-year follow-up Prestige LP. He took a subgroup of patients that had axial neck pain alone, and those patients did just as good as those that had neck and arm pain. So I think that, you know, what Todd is saying, the whole point of what we're seeing is that you do these fusions, you take a little bit away of the lordosis, and here he's showing a picture, you know, you try to contour the plate, it never gets contoured. And you know, I think it makes a difference. And that's why I think that, you know, doing the disc replacement of those patients, and as Terry has always told us, at least in the lumbar spine, Terry, I maybe have misquoted you, but you've always said that if you do the disc replacement lumbar spine, the body will find its own balance.
Yeah.
Correct. And so is the neck.
Yeah. Oh, the balance standing, we supposed to put in a good position, but I don't know. You know, I invented that 50 years ago, and I have not found what is a good position, because it depends on the age, of the waist, of the time, so to decide that this is a perfect. I know some guys who are fusing patients just because their balance is not perfect with good disc. So and it's not the vision I have. The fact is, but it's the lumbar, I would say.
And
okay,
I think
the lumbar moves, but the cervical neck moves permanently. We shake the head, we turn the head. I look to my screen here. I am looking to you, and I just see your head. If we could record your motion of your head permanently, during your sitting here, your back doesn't work so much, but your head and your cervical neck is working. And I think nobody was interested by cervical motion, because although fusion works well, 2 levels, 3 levels, we don't care. It's a real handicap to have 2 or 3 levels fusing cervical, from my point of view. And okay, so that's. I would not say everybody can do it, but I say everybody should think about it.
right.
And if they don't want to do it, send it to those who want to do that. Because for my point, you have seen when we created the disc in lumbar spine, everybody was okay, that's a good idea, okay, or not. When I started the cervical, everybody was, oh, we don't need. Here we really don't. And if and we implant 10 times more cervical than lumbar today. So that means even the access is more complex. That means that there is really a need, and by chance it's less complex than the lumbar one. So it's a very, very good. It's, you know, as you have heard, for those who have heard my talk about the seven cervical enigma, the seven cervical vertebra enigma. Why we have only 7? Yes, we are punished for that. And so as much we can preserve the motion in cervical, as better
the outcome.
Patients.
Hey, Todd,
Let me move on with these.
but just answer this one question. Now, you explained why you thought the pseudo in this girl or that patient was symptomatic, but somebody posted again, they want to know if somebody has a pseudoarthrosis and you convert it to a disc replacement, how does that take the pain away?
Well, because the pseudoarthrosis, it's the screw and the metal and the bone grinding on the bone. When you put the arthroplasty in, it's the high molecular weight polyethylene sitting in the metal implant core, that saddle that is taken to motion. So that's not a painful, no longer a painful segment. You'll see, when you remove a plate on a pseudo, and you'll often see metallosis. You'll see like etching of metal, like gray on the spine, right? That plate's moving. It's subtle, but it's doing this. A little toggling of the screw in the bone is painful. And that bone motion, I believe, is painful. And you cut it out and put an arthroplasty, the bone isn't moving against metal anymore, or moving against an inner body implant anymore that's not hooked. Now, the end plates are each attached to the bone, and the implant itself is doing the motion, and that's not painful. That's my.
Can I give the honest answer, Rick?
Yeah.
We don't know.
Okay.
So somebody posted, do we convert a hip fracture non-union to total hips?
They're doing that.
I know.
They're converting old TB patients. They used to fuse their hips, and they're putting in total hips.
Yeah, and how you can explain?
Same with knees. Old knee fusions, they're putting total knees in now.
It's an internal family question that I have got. How do you explain that when you have a failure of a disc replacement, you put a fusion, and when you have a failure of a fusion, you put a disc replacement?
I don't. When I have a failed disc replacement, it's to me, it's almost never the implant. It's either the position of the implant or poor selection. Sometimes it's a facet issue, and then I'll convert to fusion. Yes, and I have several patients like that where they have a horrible facet pain generator. But in general, I'll revise. I'll remove it. I'll remove a disc that I think is improperly placed or improperly located for the center of rotation or mobility, or there's too much shear on that particular implant, which may not be good for shear resistance. And I will remove that implant and replace it with a different implant with good results. That's a whole nother talk. But I go back. I mean, it's like if you had a bad total hip replacement, you don't have your hip fused. You get a no total hip replacement. You get it revised. So, and
I agree.
The location has to be correct. Well, do you want me? Let me show you.
Yeah. Todd, try to get your second case in. I don't know if we're going to do it.
All right. Well, I have the 2 lumbars too to follow, so I can just
Okay,
bang
well,
through
you better
really
go
quick.
fast.
I think the discussion's the same. I mean, this police detective, all neck pain, no arm pain. He said, I feel like I have a metal rod stuck in my neck. I cannot work at my desk anymore. My pain is 6 to 8 constantly all the time. Here he is, 3-level fusion, solid as a brick. You can see that. He doesn't really extend or flex there. Okay, CAT scan, solid fusion, all 3 levels. And you can see his facets aren't awesome, but they're okay. And they left a lot of residual uncinate spurring in the foramen, even though he did not have arm pain. But I knew if I reverse him and I do arthroplasty, I'm going to have to cut those out because he'll impinge the roots. So I went ahead, and you can see how I kind of cut the uncinates out on the AP film for the most part, not totally, but on the bottom one particularly. And so on the lateral, I got much better alignment than you saw in the first patient. And there's flexion extension. where he has much more mobility. You see the extension there compared to the extension before, and it's certainly markedly improved. And I think also it's not just your perfect sagittal balance that matters. It's the fact that we're able to move through that balance that also creates less pain and inflammation, that we're able to maintain that. And if you want, I'll show these two lumbar cases really quick.
Well, why don't you go through them, Todd, and we'll keep our questions down to a dull roar.
And then yeah. So this is Scott. This is a patient you and I shared. The 48-year-old gentleman from I think state of Washington. He had been in a car. He had an ALIF with a Synfix at 5'1". He had a bad disc at 4'5". He saw me. He saw you. And then you went ahead and did the artificial disc, the L4-5, and he was better, but he was partially improved. And he was aware that he had a non-union on the bottom at 5'1", and so are you. You knew about this. I think I talked to you about this case, Scott.
We did.
Yeah. And then, so, that patient, and he had a non-union there, and he said, well, gee, my pain is way better with the disc replacement because he had a tear up there. Do you think you can reverse that? And so, yeah, I took that out, and because he had a kind of a steep sacral slope angle, I went with a non-mobile core, the Pro Disc there, and placed that. And he's got some pretty good motion on flexion on the left and extension on the right. And you see he's better. He still gets some radicular nerve stuff. He had posterior laminotomies years ago, and I don't know. I think he's about 7 or 8 months out, and he's certainly improved from both of our surgeries, but he's better. And then I'll quickly show the last one and then try to get a few questions in. That's the CAT scan. I just wanted to show that the facets aren't over distracted and so on. There's no inner canal spurring. This gentleman is interesting. He's a more recent case. He had a fusion of L5S1. He's 75 years old, back in 1969 for a PARS a lytic spondylolisthesis at L5S1. So he was a young man, had a fusion in 1969. He gets back pain in 2020. He gets an XLIF at L3-4 in 21, had pain. The surgeon put pedicle screws in late in 21, and then apparently he was still in pain. He takes the screws out, says he packs the facets with bone. It continues with 7 to 9 out of 10 grinding back pain all the time. So I was like, wow, a lot of work on your facets. I don't think you're going to be a good candidate, but you can clearly see on flexion extension, he's opening and closing right over the implant. That's a clear non-union. Everybody sees that. You see the retention screw laterally there. Then you see that he has a non-union across the top of the implant. And so here's the facets. You see the facets on the right are good. The left are a bit arthritic, but they're both pretty good. So I'm illustrating this case because then, but they're a bit arthritic, but you know what? I'm not that afraid of some mildly arthritic or moderately degenerative facets anymore. And that's a whole nother thing. So his bone density was slight osteopenia. So I did do the old Rudy and I cemented the vertebrae a bit to prevent subsidence. So I think that's a 0.6 at L4-5 and L3-4. I think that's an 8.3, 11 degree. Put that in, and his pain is down to a 2.4 variable. He actually texted me this weekend. He was at one of the football games and said his pain was 0. He's actually golfing now, where he could not at all for the last 2 years. So he's very happy with the outcome. You see the flexion extension film are quite good. And the reason I did L4-5 is because if I put an arthroplasty in at L3-4 and remove that implant through the front, and if I ever need to go in at L4-5, and remember, a 5-1's already fused posteriorly, I'll never get in there because the vein's going to be too scarred. It's too difficult to go in and do a revision arthroplasty or try to implant an arthroplasty at a level between L4-5 and 5-1, L3-4 and 5-1. So I went ahead and did that, and he's got great outcomes. So that's all I had, and I know I threw a lot at you there, but I'm trying to do some of the lumbars. The key is your vascular access surgeon has to be incredibly skilled, which we're very fortunate that we have our vascular surgeon, Willis Wagner, has done over 7,400 accesses. That's all he does all day.
Hey, Todd, he was 75. What makes you think you're ever going to come back and do another operation on him again?
I hope not. I'm looking at that L23 up there, hoping that doesn't ever.
I want to ask Terry. Terry, those are the worst damn facets at 4.5 I've ever seen. Would you do a disc on them?
Go
back, Todd.
No, yes.
4.5. I thought the joints. Remember, that's part of that.
Well, yeah. Well, I mean, there's something around the joints.
I think 3.4
look ugly.
Go before the image before of the facets. More. We have a lateral view. Okay, this one is wonderful, and I can tell. If you can get the same scan in 5 years, it would be interesting to see how they are reshaping.
Yes.
Well, when he's 80 years old, have him come back.
I'm going. I talk to him all the time. He's very happy because he can live his life now. But yeah, interesting.
Well, Todd, I mean, you showed some incredible cases. You are a real unbelievable technician. You have testicles made out of steel. And it's been very interesting. I mean, I think we all learned a lot. And I thought the panelists, we all had great questions. I hope that the audience enjoyed it as well. And, we can't thank you enough. And we know we kept you busy for an hour after fighting the LA traffic, which I'm sure is bad all the time. So with that, I'd like to thank you and wish everybody a good year. And we look forward to seeing you again. A special thanks to Terry Marnay. It was a real treat to have you, Terry.
Yeah, Terry, thanks for staying up.
Yeah, no, he's in Philadelphia.
Oh, he's in Philly. Oh, that's right.
No, Todd, for once, it's not 2 or 3 o'clock in the night. I want to say thank you for doing that for your patients.
Thank you.
Somebody is doing that.
I think we need to push the envelope. I really believe in
some guys can do that type of thing.
Yeah, this is not beginner surgeries, but this is. I just want people to think more. For us as particulars, arthroplasty surgeons, I think it's so important. We look at motion restoration and we keep going and pushing the envelope. And so I'm pushing it. I know we'll get critiqued, but that's how it works.
Well, somebody's got to do it. Otherwise, we're not going to think about it, Todd. And the techniques that you're developing, I think, are helping us all. I think that, all of us here believe in arthroplasty. We're not, we look for reasons not to do a disc rather than to do a fusion, which is the opposite, the way of most of our colleagues think. They think fusion first.
Yes,
so,
100%.
Anyway, don't forget. Oh, hey, Matt's on. Matthew Scott Young. Matt, nice to see you. We're hanging up now.
Yeah, no, that's good. That was very interesting, Todd. Fantastic.
Oh, hey, Matthew. Hey, there you are.
Yeah.
Thank you.
All right. Well, don't forget to claim your credits. The number's 1028. 1028 to get your CMEs.
Thank you, Todd. That was good, stimulating discussion. Just exactly what we want out of this hour. So you did good.
Thanks, Jack.
Appreciate it.
All right. Take care.
Good night, everybody. Good morning, Matt.
Good night. All right. Bye-bye.
Bye-bye.